Are you singing?
Mm-hmm.
Sure. We are live. Yeah, we are live. Mm-hmm. So let's make sure that everyone gets the link so then I don't get interrupted. So broadcast. So when I do the broadcasting, they think that I'm sending individual emails or individual messages. And I get messages back from them.
Does it go to the whole group?
And then Carlos says, "We see you." I know, Carlos, you see me. Thank you. Good afternoon. So since it's a long weekend, Carlos, we are just taking it casually. So that's what it is. So otherwise, your boss is aware of the fact that he's live. But thank you. And my friend, one of my best friends, is not listening to me because he's asking me a question that's not related to the live event. That means Bekir Elmash is not listening again. Okay, so but because he's supporting our charity donations, so we are not gonna be upset with him. So good afternoon. I'm just waiting because we didn't post the event early on, so waiting for a couple people to sign up. All right, hopefully everyone is doing well. So Buddy is right behind me, so if you hear any noises, that's absolutely not coming from me, so it's coming from Buddy, obviously. But you can always blame other people or me. I will start in a couple of minutes. So I'm going to actually bring up our world meter before we start with the PowerPoint. Okay. Good afternoon, everyone. Sorry, we are a little bit late. I thought we posted the event. Apparently, when we do so many of them, sometimes we do skip these. But we are here. Today, we are going to give you, right before the Labor Day weekend, we are going to give you some updates on the COVID and the vaccination and what's coming up. But while we were prepping for this event, we wanted to make sure that it was necessary to share what is happening with COVID cases, because those numbers are increasing, and it is important to know that right before the long weekend, holiday weekend, numbers are high. So 2 days ago, with 186,000 total number of new confirmed cases, and yesterday that was 177. So 177, 186, that's almost 400,000 cases. That's a lot of cases. And as of today, we are at 10,400, because this is real data that's not going to be showing a lot of data yet. But at the end of the day, it's going to be high. So why we are sharing this, obviously, long weekend is coming up, and we want to make sure that everyone is prepared for these events. Now, let's actually start with our regular session. So Tanner is back. So
Buddy as well.
Everybody's right behind me. So now our PowerPoint is, before I do that, I need to make sure that I disable my team, Microsoft Team, because you guys are sending me messages during this. Okay, so. other than the COVID numbers, we are going to discuss the chronic care management and what our organization has done so far, and also advanced care planning. But before we do that, I'm going to ask Tanner to give us the vaccination update.
Sure. So thanks, Kemal. I know the reason we wanted to kind of bring up the Worldometer again as well, as Kemal mentioned, it's something that we keep an eye on and have been for a while now. But it's interesting to kind of take a look at this increase in cases that we'll also see kind of on a local scale here in Delaware as well, as it relates to our continued vaccination effort. So first, I'm sure everyone's pretty familiar with this graph at this point, wanted to take a look and see what the percent of the population in the United States is vaccinated and where that puts us on the daily case rate, or excuse me, for the daily vaccination rate. And we're starting to see that increase again. I know we had seen the drop over the summer, throughout the summer months. We had progressively gotten lower and lower, but as cases have started to increase, which Kemal was just showing us, we're seeing some of the highest case numbers that we've seen since the spring, late winter, early spring of this past year, where we did see an increase in vaccinations there as well. We're starting to see that happen again here as we head into the fall. So it's something to be mindful of and keep an eye on, with a whole lot of different things going on, whether it be holidays or it be the flu season that is starting to come up onto us. We're going to start to see some increases in both of these numbers. So what I mentioned was, what does that look like here locally in Delaware, where we're seeing signs of a similar trend. So as the population is increasing for the amount of people who are vaccinated here in the state of Delaware, we're just over that 60% mark covered, 61.9%, just hovering at that 62% mark here in the state of Delaware, which is what we're seeing on top. And I like this graph because it shows it against the rate of cases as well. So you can see that the trend is starting to pick up just a little bit. So the vaccination rate here in the state, as well as kind of mirroring what we're seeing in the country as a whole, is we're starting to see an increase in that rate number. At the same time, we are seeing that in tandem with an increase in cases. So whether that be due to higher transmissibility of new variants that are around, whether it be everyone still gathering for upcoming events and holidays that we're seeing. Of course, you got a lot of end of summer travel happening. There's all kinds of different factors that are going into our increase in cases, but we'd like to see that vaccination number rate increase at the same time, which is a good sign. Oh, come on, I think you're muted yourself.
I did, because Buddy is like right behind me, as I said. So the long weekend is coming up, and what we know from that is the issue of people are socializing. Also, there are some events. US Open tennis is on. And interestingly, US Open actually is asking for proof of vaccination for at least one dose. And then I think, Tanner, you got the Firefly. Is this end of the month?
Correct. Yeah, because it's coming up. So it's something that's pretty, I wanted to keep an eye on this one, being that it is a large gathering event here in the state of Delaware. It'll be interesting to see how that affects communities around. I know a lot of people come from out of state, obviously, and travel come in. But a lot of people here, of course, it's going to end up affecting the local community. So that is coming up at the end of the month. And right now, their requirements are either proof of full vaccination or negative testing before actually getting into the festival grounds. So that was kind of what a lot of what we were seeing for a majority of large public gatherings, public events as of late. But we know that we're going to, of course, be seeing more and more of this happening, not just here, not just locally, across the country. And it kind of gets into our, as it kind of mentions up top here, this was something else I had pulled from the state of Oregon, saying their sporting events, for a majority of their professional public sporting events, they are going to require proof of vaccination. So it's just highlighting here kind of some of the range of reaction that we are seeing to the new rules, because it's both, we're seeing the mandates coming. We knew that that was coming, something we had discussed. And we're also seeing some places, some events, being able to still hold on to the vaccination requirements or the testing. So it's just interesting, as we, like you mentioned, we're going to start to see more and more gatherings coming up, how public policy reacts to that.
So I think the other important issue that we discussed before is different professionals. There's shortages coming up. So now the schools are open, so the teachers are at risk. So the news that we have, I'm going to try to do this from here. See, when I have one screen.
Oh yeah, the setup's a little different.
So I have to go back and forth. So let's see. All right. This is from California school. They are already facing with the teacher shortage. Now, when I see this, obviously, what we are looking at is immediately, because we are in healthcare, and then 2 or 3 weeks ago, 3 weeks in a row, we talked about the providers having some discomfort with patients who are not vaccinated, and then them coming to the office. So now, Tanner, so let me ask you this, like how you feel about. I think you're part of that discussion. I don't know if you were there or if it was Anthony with me. So providers are already having this issue now. Teachers don't have a problem going in, but their problem is they get infected, so they're at risk, and they're not able to. There's not enough. There are not enough teachers there. So, but then providers are going to have similar issues if they're not being careful. So, what's your take on that?
Yeah, no, I don't believe I was a part of those original discussions, but this is actually something I had seen in, I believe, a health system somewhere down south, where it was one of the first cases publicly where a provider had said that they were not going to be seeing, or referred not to see unvaccinated patients. So it does, and we're seeing how that could be affecting professions with the substitute teaching, with teachers in these large school systems, particularly in California. One of the reasons I think it's such a problem there is because they have one of the largest public school systems in the country. So with the students and everyone gathering in large quantities in these buildings, again, we're seeing the effects of that happen by, like you mentioned, maybe they're getting infected, or they have family at home that they don't want to get infected, so they're staying home, and it's causing those ripple effects. So I could see it being a problem in our healthcare setting as well. I know originally, at least for our experience, the whole purpose to keep patients out of the clinical setting and transitioning to telemedicine visits was for that very reason, to protect our providers and to protect the medical staff. So it certainly poses a level of a risk to the staff, and something to be considered, I would say.
So, well, because again, we are in healthcare, and then we are seeing this every day. We are concerned about our providers, and I do follow up with a lot of patients these days who are actually not happy with providers not maybe willing to see them for non-emergencies, or the reasons that they don't need to be in the office, and then they're unhappy for the video visit telehealth. Well, we have to protect them, and we have to protect providers, so then we can actually help the other people in a better way. So that's kind of like the reason. Now, this doesn't mean that we have to compromise the quality of what we are providing, but there has to be a good balance. And at this point, personally, I do not believe there is any good reason for anyone not to be vaccinated. Do I understand? I don't. Do I respect someone who's so strongly about it? Yes, because I don't have a choice. But understand. But at the same time, there's a bigger problem with this. So then I'm not going to risk our providers, other patients, my own families, my friends' life. If it's not something that it can be taken lightly. And United Medical has done so much. It's amazing how much, even with these events, how much we try to outreach to the public, how much we, with the business development, with our care coordination, with our providers being available for patients to get the vaccine, being open for these times. I know in some cases we don't get enough recognition for what we do. In some cases we don't have this nonprofit, in front of our name, but we are doing more than what nonprofit organizations are doing for the society, for a fact. And we are proud of that, and we'll keep doing it. But at the same time, everyone needs to take the ownership on their own and then make this easier and make responsible decisions. So that's what needs to happen from that side. Now, Tanner, we have another topic that we wanted to discuss today, and that is something that changed from day to day what I do. And this has been maybe 2-3 months now. So for those who know what I do every day, everything that I do is on my schedule, including my personal stuff. But business is heavily booked, and 10 to 11 used to be and still is our bariatric case conferences with a team of 8 to 10 people from different backgrounds, including our bariatric surgeon, Dr. Isaiah Zerigao, and the facility and the practice. So, and then now, last 2.5 months, we are doing another case conference, and that's around our accountable care organization. Our nurses for the last 2.5 years, since November 2018, they have been doing the case reviews and communicating with our providers, and that used to happen in the patient's chart, and they've been talking to the providers and giving the feedback. But now we took that to a different level. So now we are actually taking a certain number of patients, and based on their chronic illnesses, based on the need that they may have, the severity of the issue that they have, and then we are actually discussing those patients and then see what can be done for these patients. So that's something that we started, and Monday through Friday, every day, 11 to 12, with our clinical integration director, Donna Danko, and also from the business development with Kim Taylor and our nurses. We discuss these cases. Our goal is to make these reviews more meaningful. Now, many people don't understand what that meaningful is. Well, meaningful means meaningful. Meaningful means that you can make an impact. You can actually, like, just following up, and then, in the old days, they used to call these things cookie cutter. So everyone needs colonoscopy. No, yeah, but I mean, if you are trying to follow up someone who's 87 and trying to get them for a colonoscopy at the hospital during the time of pandemic is not a good care. Mm-hmm. So, like what we have seen, for example, a patient who is 89, real case, and has given nutrition counseling at one of the hospitals. Well, it's during the pandemic, 89-year-old, what type of nutrition counseling they are getting? Patient needs some specific diet instructions, perhaps not in the hospital. We have a specific accredited organization for nutrition and diabetes, so we can take care of that without the hospital getting involved. So meaningful is that. Meaningful is the patient is not able to buy. A lot of patients who are on Medicaid, they don't have access to purchase what they really need. Like when we say healthy, like there are a lot of people like what's that store named the whole store. I don't do shopping, so I don't know the names anymore. Like I remember ShopRite and the Whole Food. Yeah, thank you. Everything is so expensive, right? So okay. My friend Baker is still not really listening this, but at least he can watch or stop maybe messaging. Hello, like let's see. When he needs something, he doesn't care. So okay, so just maybe he didn't get the memo. So Whole Food is expensive. Even I know that. What's that place over here? I have to start shopping. I don't know if the places. I still call Happy Harry's, but apparently it's not called Happy Harry's anymore.
I remember when there was one of those around.
Walgreens. It's been like 15 years, but I still call them. Yeah. So Baker can actually connect if he wants, so we can send him a link if he really wants to connect. But anyway, I really don't remember that store's name here. Is it really bad? So James, if you're watching, you can text me. Anyway, these expensive places, healthy is usually equal to expensive in the overall perception of it is. But we have people, we have our nutritionists, we have our social worker who are able to help these patients in a way that, no, that's not the case, actually. They can actually hook them up. We work with the food bank, as you know. We are not only financially helping them, but also we are able to communicate those events with our patients. So then some patients do need more help. Now, one of the other big problem is those patients, sometimes they don't know what these services are and what's available to them. Right. And they may have some of these free services through their insurance companies, but they don't know what they are. And a lot of patients, because of the fee-for-service model in the last several years, 15, 20, 25 years, they are, in my opinion, they were taking advantage of the system, this system that's created by CMS. So, CMS says, I pay you per patient. Every time you see them, you get paid. So, that's trained people to get paid in that way. So now what we have done is, and what we adopted is value-based, and we contracted with 6 different insurances, including Medicare. But then what we see is Medicare actually, including Medicare and other insurances. Remember, Tanner, like part of your training with me was understanding what TPA, third-party administrator, and understanding insurance company, not being an insurance company, but also just the claim processor for the big employers. So if you don't really remember that all the time, which we do, even I forget this many times. So this is for the private insurances. If you don't remember that, and then Medicaid have managed cares, who's paying that is the state. State is getting paid by our tax dollars. That's 1/3 of the state budget is coming from going to actually these expenditures. So now what's surprising is Medicare is still promoting fee-for-service model. Now you're going to say, well, come on, why do you say that? Maybe you were going to say that, but maybe you don't, but I'm going to say that on your behalf. So there is a chronic care model, one, and there's also advanced care planning. There are two really intense, time-consuming, and it's difficult to maintain in the, difficult to achieve in the primary care setting. And it doesn't have a good structure, so specialists can also do the same thing. But I'll tell you why. I'm going to actually just maybe open up this a little bit, so then we can kind of put a little bit. So if Anthony is watching, he's probably getting nervous, but he actually does. I like him when he's nervous. So this whole fee-for-service is getting to like when you are trying to get us out of the fee-for-service and going to the pay-for-performance, then why are you still, Medicare, promoting the fee-for-service? And then why are you not looking at the what's doable? Because remember, like providers, they have been paid for fee-for-service for so long, so there's that habit of fee-for-service already in their DNA. Right. So we are trying to get that out of it, but then they are just still trying to sabotage our value-based pay-for-performance models. And who's doing this, in my opinion, is CMS. If CMS is
well, sorry, could you just go into maybe some ways how CMS continues to promote this?
Chronic care management, there's a CPT.
So these are new.
Yeah, I mean, they've been out there since 2015, right. 2016. When you say chronic care management, and here's the CPT, and here's another CPT, okay? Everyone knows these CPTs. Mm-hmm. Now, there is the patient eligibility. A lot of Medicare patients have these chronic illnesses. Now, Tanner, so I'll come back to this in a second. So remember, hypertension, I-10 is a chronic illness. Mm-hmm. So, and remember from our studies, how many patients have hypertension? Everyone has hypertension in Medicare. I mean, I say everyone, but I mean, it's 65 to 70%.
And that's just one of them.
You have hypertension? You said you have hypertension?
Not yet.
No. I mean, Medicare patients, like 70%, close to 70%, like, and especially with patients that was even like clear. But everyone has it. Why are you trying to put some time and staff time? And then, if you do this, well, value-based pay-for-performance is already in place. Right. So you tell me that you are going to give me something at the end of it if I do X. But then at the same time, you are saying to the others, well, if you actually do this, I'm going to still pay for fee-for-service. And fee-for-service is part of my shared saving, is part of the cost. So it's almost like you are sabotaging and not letting me becoming a game changer. So this year in 2020 program year, our ACO finally made a good number for our providers. It took 5 years to get to that. But then what we find out is we do some practices, picked up chronic care management. They don't do that. So, but then I look at other ACOs, other practices like outside of us, everyone is doing this. Mm-hmm. Who's making this decision? If CMS director is watching this, call me over the long weekend and I'll talk to you and I'll educate you. You don't know what you are doing if you are approving this. Now, if you are not preventing certain things to happen, because you cannot, tell someone, oh, I'm going to promote the quality, but then you still promote the quantity on the side, then why do I need to get out of the quantity? Because it's easier to make it. Now, these patients don't know what they are getting and what they are not getting. And I'm not saying all of them is right, all of them is wrong, but all I'm saying is this is not the model that we want to be promoted by CMS because it's confusing the patients. Now, let me see what we have put up here. So I can tell you the diabetes, hypertension, COPD, cardiovascular disease are like the top, I think easily 85% of the patients. I mean, they can challenge me if I'm wrong. They all have it. There's no good qualification. No. Now, why we started? Why we let's just share this one as well. Why we started with this.
Yeah, I thought this is a good job of, just for someone who might not, again, we talk about chronic care management, and on face value, you can kind of get an idea of showing those chronic conditions and understanding how it's not just the management of these conditions, but there's a lot more that goes into it. And I think that this will be helpful kind of understanding why it takes such a team effort from our end, and why the ACO has done such a good job to go above and beyond, especially recently, on making sure all of these things are checked. And whether it be someone from the coordination team or the clinical integration team or the business development team, it really takes the team effort from the ACO.
So Tanner, why we actually opened this up with the case conference and the nurse review. The selection of the patient process is extremely important. Not every patient needs this level of.
Right.
Actually, I can tell you, I don't know if we included some of our, it's coming up. So the way that we did, patients who are really non-compliant, who really need the most support, are the non-compliant patients. So if you pick the stable patients to receive the service, what outcome are you expecting? So let's go back and let's just, because we want to use this as our tool for our network, our people to understand, so as an education material too. So we are saying that, so okay, your patient's eligible, they are at risk, this is someone who's not going to get better if they're not in stable condition, but these are the risks, these are the diagnoses that they need to have, fine. Then there has to be a patient center specific to that patient, not like a clone, like cookie cutter. That's not the case. There has to be a patient. That patient is different than other patients. That patient's hypertension is different than the other patient's hypertension. That patient's comorbidity is different than the other patient's comorbidity. So you are not going to copy paste, and get $100 a month extra. That's not going to happen. So I'm doing this public service for around the country for all Medicare patients and all other practices who may not understand what they are doing, because Medicare is coming back and auditing the practices. These problem lists, expected outcome and prognosis, measurable treatment goals, symptoms, plan interventions, medication. Some of these you would say, oh, I'm doing those anyway. No, you're not. I mean, some of them you are doing it.
Yeah, and I know you saw already it's coming up, but would you want to go into a little bit of what exactly the process is for the ACO? So I've gone in and included some of these reports that you guys are going over.
We were focusing on this case conference. We were focusing on the outcome and see what we were able to actually get from these patients. Now, I'm going to actually share some specific reports before we get into that, but let's just actually look at these. Like when we look at some of the issues here now, the problem is a lot of patients do have patient compliance issues. So you can't bill chronic care management for these patients. They're not non-compliant. a lot of them have refusals. You can't really do anything with those. So the meaningfulness that's like, let's just tie it into the meaningfulness. When we say meaningful, if the two highest group is non-compliance and refusal from the patient, how are you going to have a meaningful outcome, meaningful impact from that? So just to show, this is our test buddy who's right behind me right now. Well, in case there are some patients who don't understand some humor, so he's a dog, but he's my puppy. So we use him as an example. So we have these care follow-ups. So when we schedule his PCPs, because in some cases, patient leaves the office without a PCP follow-up, so his is scheduled. But then when we send him for behavioral health, he refused to be followed up, so patient compliance. Actually, he refused, patient refusal. Yeah. And then for the nutrition, he was unable to be reached. So then it was patient compliance. Now, we build these to make sure that we have a good way of measuring the outcome, because Medicare is saying that you can do all of those, but you have to be able to measure the outcome. Now, I think I have, so this is Buddy's chart in our QuickBase. Are you guys able to see it?
Yeah.
Okay. So this is a test patient, obviously. So the way that we do now is we are able to send standard emails. So he has no show, he has to follow up with his PCP, he's high risk for diabetes, regular diabetes, patient portal, all these. But once we complete his regular review, his review is assigned to follow up with different specialties, like his own PCP, nutritionist, and in this case, behavioral health. From here, if we are able to, like we call him 3 times, if we are able to get to him, then we schedule, or whatever the outcome is, we are able to actually set it up from here. So if we are not able to, down here we have his follow-up. What is our goal? So our nurses are able to say, okay, this is what I would like to, this is a routine check. And with those 3 different PCP, this and that, we would like to see X, Y, Z, and then they put their comment. And then in the case conference, we add a comment, and then we say, next step is PCP communication needed, or A1C management is needed, or drug screening is needed, or nutrition compliance, like whatever that is. So, and that way we are able to keep that patient on the list until patient is either improving and now stable, or they're not improving, so then we can actually dismiss them from this list. So as you can see, it's not as simple like, oh, I would just want to build, and then that's fee for service. So you are not on the billing side as much. So we want our primary care physicians to see the patient more frequently. Now, that doesn't mean that more fee for service, because when you see the chronic, especially patients with a lot of problems, when you see them more often, you are able to help them more often. But when you put them some program that you are not 100% hands-on, and then you are billing them, that's not a good thing. That's not helping. Now, here's the thing. So you have average, you see the patient 3 times before chronic care management. Then you see them average 3 times, right? So you see, like, let's say you get $100 a year, like per visit. Primary care was getting $300. Some primary care now adding this chronic care management, and then they can get additional $1,200 on top of that. Why? Why is CMS allowing this to happen? Now what CMS is doing, now they're saying, oh, we are auditing these don't do it from the beginning. Don't mislead them. CMS now is auditing practices for chronic care management. So PCPs don't have time to understand all of these. So when you say, oh, this is what you need to do, and then you don't have 100% clear guidelines, you are setting them up for failure. I think CMS is at fault. So they kind of almost sabotage these practices. I think we lost Tanner maybe, or maybe you guys lost me, but someone is lost. Okay, so I think if I'm still live, if someone can message me, it would be good. So CMS is, in these cases, CMS is almost sabotaging primary cares, and it's always happening to the primary cares. So they're not helping the situation. So, and our goal is to make sure that we are helping our primary care, but also we want to help our patients, because this has a cost to the patients. If the patient doesn't have secondary insurance, these expenses are picked up by the patients. There's 20% of the cost of these are being paid by the patients. So yes, so I'm still alive, thank you. And I think Tanner will be back. That's kind of like what our goal was today, give two different messages to two different groups. One is for our group of our primary care and group of primary care in the country. If you do chronic care management, you need to do that in the value-based contracts. You cannot really just do one thing with the pay for performance, but then you still have the old habits of the fee for service. Fee for service is only good if you have a good balance. It is not okay to pick up new fee for service practices, adding it on top of the old habits, and then just sabotaging our pay for performance contracts. Now, our second message is to the patients. So you pay for these services. If you are receiving them, demand for the service, number one. Number two, these are costly services, and if you don't have secondary, you end up paying 20%, and you shouldn't be paying for this. It's not right, and you should demand for the service. So that's, I feel better if everyone is aware of what's available to them, because our goal is to help you. And while we are working so hard to make this better, we don't want CMS to kind of misguide us, mislead us. We don't want our primary cares to get in trouble because CMS is not leading us properly. We don't want some third-party chronic care management companies to take advantage of our primary care physicians, because there are a lot of sharks out there, and we are not going to let that happen. And that's what our position is. And Tanner is not coming back. I guess this is, he's in the business office, so we are in two different locations today. So one other thing that we have is outside of the chronic care management, there's also advanced care planning, which is another time. Hey, there. So advanced care planning is another time consuming for the primary care, which we don't really actually, the problem, we don't have enough resources to do that kind of service. It requires 30 minutes minimum from the PCP. We have shortage of PCPs. I'm being honest with everyone, 30 minutes. If I can do 30 minutes for the visits, that would be great. So on top of that, I'm going to sit down and then spend 30 minutes with the patient and the family for the advanced care planning. That would be really nice, but that's not in the PCP offices, guys. So because Medicare is saying that it has to be with the billing provider, it's not like with anyone. Like they're not, again, they are just setting us up for failure. So, and no one is going to tell you this the way that I'm telling you, because everyone is like just hiding behind these like politically correct terms, but they're all liars. So I'm just telling you very openly that this is not feasible. No one is doing 30 minutes advanced care planning anywhere in the country. So you go and then see how many patients they see a day, and then how many patients we have to treat, because it's on top of the visit they require that. Mm-hmm. Like if I see 25 patients, then I have to do. I'm not a physician, but provider has to take care of them, and it requires the provider's time. It's not saying that MA can do it. It doesn't say that check-in person can do it. Who has that time? Again, CMS is just pulling these from their behind, so they are not realistic. They didn't see. They I don't know when last time they have been in a private office or a non-profit office. Like probably they were never. So if they can only visit these offices, we can help them, but they are not. So I'm just telling you that don't do it. And if you're a patient and if you are being billed for this, question. So that's my public service. So providers don't do it because you are not providing that service. Patients, if you are being billed for it, be aware of that. Don't let that service to be billed to you because that's not right. Now, I have two parents. My both parents are alive, and I'm so thankful for that. They're both Medicare ages, and if I see that on their bill, I would be extremely upset. And I treat every patient in that age group as my parents. So it is not right. So hopefully this makes some impact in the society that we live in. But speaking of the society that we live in, this past week was a difficult week for our non-human friends. SPCA needed a lot of help. Brandywine Valley SPCA, especially, as most of you know, that I'm on their advisory board, and they did bring a lot of animals from the hurricane area over. It was last Saturday, and I think there are some over the weekdays as well. And they do need a lot of help. We would appreciate if you can do more support. I know that it is. What's really interesting, so that Saturday, where all the animals, they actually find a home, I believe, but there are more that they are bringing, and they need a lot of support. We would really appreciate it, and we are trying to help them as much as possible from our side. Hopefully, you can be part of that as well. Right. So. Long weekend, so Tanner, you missed one of my slides, so
it's okay. For the computer issues. I'm not sure what was going on.
It's okay, it happens.
I was following along and I looked at myself. I could see I was frozen. And all of a
sudden, we don't have like 100. We don't have like 100 different production team. Like there's only two of us, and then maybe three. So when it fails, it fails. So, but one reminder for the long weekend is, what was that old saying that we have is, we have to learn from our mistakes, right?
Right.
At least we have to learn from our mistakes. So long weekends are, it's triggering the number of cases. Mm-hmm. So 10 days after, we see a big increase. And this is another one of those.
Right.
I'm not saying that don't do anything, because I'm going to be in one of the social events. I got COVID and I got 2 vaccine, and I don't socialize. Many of you know I've been probably very limited number of stuff that I have done in the last 18 months. So, but whatever you do, please be careful. Please get vaccinated. Please get tested, and hopefully we can go through this long weekend without any big trouble. Tanner, anything you want to say before we close?
No, thank you very much, Kemal. I did want to just reiterate that fact. I know we continuously go over cases throughout the country, especially here in Delaware, and I know it's something that we kind of just continue to repeat ourselves. It might feel like it might lose some importance, but now more than ever, it's going to be important to be mindful. Like you mentioned, we saw the same patterns last year. So like Kemal mentioned, doesn't necessarily mean to not do anything, but just be mindful, be careful, and I hope everyone just has a good Labor Day weekend. Excited for the
all right. Well, thank you so much. Yeah, thank you so much again. So this is our last long weekend for the summer. So summer's over.
Yeah, technically, I guess it's the official end of the summer, unofficial end of the summer. That is.
Yes. So, all right. Well, thank you so much for being with us today and next week. We don't have the Bariatric Friday, but we are back after next week. So we'll see you soon. Our event, because I'll be in Turkey, this event won't be. Both events will be back 2 weeks from now. All right. We'll see you soon. Thank you so much. Bye-bye.
Thank you.